Welcome to the Radiology Review Podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review Podcast, your top free on-the-go source for radiology board review. This episode continues the discussion of nuclear medicine and the thyroid. I stated on the last episode that I would cover additional topics on the thyroid pertinent for the ABR core exam. Diving into the material further, there is a lot of information to present here. On this episode, I will get into more specifics regarding iodine uptake and imaging appearances of classic entities to include toxic multinodular goiter. I will then conclude with some discussion paving our way for the topic of thyroid cancer that will be covered in detail on the final episode, at least for now, on nuclear medicine of the thyroid. So this will be a three-part series. At the conclusion of posting these podcast episodes, I will make a free downloadable study guide available on my website, theradiologyreview.com. There is other material you can also check out at theradiologyreview.com, including the newest top radiology books to consider. I include book suggestions for each main subspecialty area of radiology, as well as book suggestions for medical students interested in radiology, and have some additional book recommendations that may be of interest to the radiology community, so go ahead and check that out at theradiologyreview.com. Congratulations to those who have recently completed the ABR core exam virtual edition. I cannot be more happy for those of you who have this exam completed and behind you. The early feedback I have received is that the exam is certainly a challenge, but that is not a surprise, and that is why we study hard and prepare to succeed. Without further ado, let's get into the questions and answers for this episode. First question: how long must one abstain from breastfeeding after receiving iodine 131? After receiving iodine 131, lactation must cease for that child. This is due to the risk that iodine 131 could pose to a newborn child or young child's thyroid in terms of ablation or making the child hypothyroid, which is absolutely not desired and can severely impact normal childhood development. As a result, iodine 131 is simply contraindicated in pregnancy and in childhood and in the setting of lactation. So if a lactating person receives iodine 131, they need to stop breastfeeding, at least for that child. In subsequent years, the iodine will be gone and breastfeeding will not be an issue, but no more breastfeeding for that child. I also want to clear up one point of potential confusion here. Depending on which site you are at, iodine 131 may be used exclusively for iodine therapies. However, I-131 can be used for diagnostic purposes as well, including iodine uptake. Iodine 123 can be more expensive depending on where you are, and some institutions may simply decide to use very low doses of I-131 for a study such as iodine uptake or a thyroid scan. So either I-131 or I-123 can be used for thyroid imaging. However, only I-131 is used for therapy because I-131 has the beta particles that can be used for therapeutic effect, whereas I-123 has no beta particles or other therapeutic particle. Let's move on. When can breastfeeding resume after receiving iodine 123 or Technetium 99M? For iodine 123, breastfeeding can resume after about 2 to 3 days. For Technetium 99M, one should wait about 24 hours to resume breastfeeding. Next question: what are approximate normal values of iodine uptake at 4 and 24 hours? An iodine uptake test normally provides values of uptake at 4 hours and at 24 hours. and range of estimates vary, but I personally remember a normal range of 5 to 15% at 4 hours and 10 to 30% at 24 hours. That is easy for me because I simply double the 4-hour range of 5 to 15%, and that gives me the 24-hour range of 10 to 30%. On board exam questions, they should make it obvious whether a result is in this ballpark range of normal or if it is clearly abnormal. I wouldn't expect that they would give you, for example, an uptake of 3% or 17% at 4 hours and ask you if this is normal, because that is simply too close to the normal range. They would give you something much higher, such as 30% at 4 hours, which is about double the normal range that I told you of 5 to 15%. So I wouldn't expect that they will require you to make really subtle borderline calls. However, you do need to know some of these normal ranges to help you answer questions. So I personally remembered 5 to 15% at 4 hours and 10 to 30% at 24 hours, and that has served me well. Next, elevated radioiodine uptake can be seen with which classic entities? As in many things radiology, the list of potential diagnostic entities is somewhat large, but I'm going to focus on the most high-yield entities for the ABR core exam because you simply can only remember so much. So classic entities associated with elevated radioiodine uptake that I would remember for the ABR core exam include Graves' disease, early Hashimoto's, as we discussed, that early Hashimoto's may have increased uptake of radioiodine, and I would remember dietary deficiency of iodine. With dietary deficiency of iodine, the thyroid is so hungry for iodine that when the body receives iodine, the thyroid simply takes up as much as possible. Dietary deficiency of iodine is very rare in the United States, and when we see increased radioiodine uptake, the number one entity you should consider is Graves' disease. And if it's not Graves' disease, then look at other entities to include early Hashimoto's. Next, how do TSH values help distinguish between Graves' disease and dietary iodine deficiency? Because both of these entities will have increased radioiodine uptake values, one can use TSH to help differentiate these entities, as well as obviously something like dietary history and clinical history and symptoms. Graves' disease would be expected to have a low TSH value, whereas dietary iodine deficiency would be expected to have an elevated TSH value. Remember that the TSH is released from the hypothalamus as part of the iodine feedback, and if the body is seeing a lot of thyroid hormone levels, TSH will be suppressed from the hypothalamus. If the body is seeing low thyroid hormone levels, the hypothalamus will ramp up TSH values to go and stimulate the thyroid to produce more. Therefore, with Graves' disease, where thyroid hormone levels are abundant, TSH will be low. With dietary deficiency of iodine, where thyroid hormone levels will be low, TSH will normally be very high. Next question. How does renal dysfunction affect iodine uptake values? Renal dysfunction may cause elevated levels of iodine in the blood pool, and because the thyroid has more iodine at baseline, it will take up less radiotracer due to competition between the iodine in the blood pool and the administered radioiodine, independent of TSH values. So in the setting of renal dysfunction, one would predict lower radioiodine uptake values. Next question. What are some medications that can classically lower radioiodine uptake? Medications that can classically lower radioiodine uptake include thyroid blockers, such as methimazole or propylthiouracil, as well as nitrates, and importantly, iodinated contrast that is given IV, and amiodarone. It is important to remember that before an iodine uptake study, and especially as well before I-131 therapy, you need to pay attention to the last administered dose of intravenous contrast that had iodinated contrast materials. That is a really high yield concept for the ABR core exam. And I would also remember amiodarone can interfere with iodine uptake. Next question. What is the significance in Graves' disease of an elevated 4-hour uptake and a 24-hour uptake that is lower than the 4-hour value or even within normal limits? The answer is that a high 4-hour uptake with a lower or normal 24-hour uptake means that the thyroid has very rapid thyroid hormone production and a rapid iodine turnover. And this turnover can be so rapid, in fact, that the tracer was depleted by 24 hours as it already had been trapped and organified and subsequently released from the thyroid. This is a sign of a very active Graves' disease that is really, really ramped up. Do not fall into the trap of saying that this is normal because the 24-hour uptake value may be normal, when in fact it is manifestation of a very active Graves' disease. Next. What is the classic thyroid scan imaging appearance of toxic multinodular goiter? Toxic multinodular goiter will show one or more hot nodules on a background of a cold gland, as the hot nodules preferentially take up all or most of the radioactive iodine. Hot nodules on a background cold gland can be seen with a toxic multinodular goiter, whereas warm nodules on a heterogeneous thyroid that demonstrates normal background uptake is seen with multinodular non-toxic goiter. For review, Graves' disease is expected to show homogeneous diffuse uptake throughout an enlarged thyroid gland and would not show the focal and heterogeneous uptake seen with toxic and non-toxic multinodular goiter. And to guess at the difference on imaging between a toxic and non-toxic multinodular goiter, look to see if the nodular uptake is so intense that the background thyroid uptake is lessened, and that will point you towards a possible toxic multinodular goiter that would be confirmed if hyperthyroidism or increased radioiodine uptake is identified. Next. What are typical thyroid uptake values and clinical histories for patients with toxic multinodular goiter? With toxic multinodular goiter, thyroid uptake values may only be moderately elevated, but they should be elevated. For example, uptake around 40% at 24 hours. And for reference, a classic Graves' disease case on the ABR core exam may show uptake around 70% at 24 hours. A classic history would be an elderly female with symptoms of hyperthyroidism, such as tachycardia, weight loss, insomnia, anxiety, and so forth. Next question. If a patient presents with a low TSH and a high T3, T4 value, what entities should you consider, and how can thyroid uptake values help you differentiate between potential possibilities? A low TSH and an elevated T3, T4 can be seen with multiple entities, including Graves' disease, subacute thyroiditis, solitary autonomous hyperfunctioning nodule, and toxic multinodular goiter. Radioiodine uptake would be expected to be low in subacute thyroiditis or dietary iodine overload, and elevated in Graves' disease, toxic multinodular goiter, and solitary autonomous hyperfunctioning nodule. Next question. If a thyroid nodule is cancerous, will this nodule most likely be hot or cold on a radioactive iodine thyroid scan? And how would a cancerous nodule classically look on an FDG PET-CT scan? A cancerous thyroid nodule is most likely to be cold on an I-123 or I-131 scan, and a cancerous nodule would expect to appear hot or demonstrate FDG uptake that is focal on an FDG PET-CT scan. Key is to remember that normal thyroid takes up radioactive iodine, so if a nodule is cold and therefore does not take up iodine like normal thyroid, that means something is wrong with that nodule compared to normally functioning thyroid tissue. And that can be evidence of cancer with derangement of normal cellular function. As we all know, cancer can be hypermetabolic and really likes FDG in many scenarios, and a focal FDG-avid thyroid nodule should raise suspicion for possible thyroid malignancy. Next question. Are most cold thyroid nodules cancerous? The answer here is no. Most cold nodules will still be benign. Additionally, multiple cold nodules in the setting of multinodular goiter are more likely to be benign compared to a single cold nodule. Nonetheless, if a nodule is cancerous, it is more likely to be cold, and we need to pay attention to cold nodules, with the exception, and especially on the ABR core exam, of multiple cold nodules in the setting of multinodular goiter. In that setting, you can be pretty confident to say that it is benign. But if they show you a single cold nodule on the ABR core exam, I think they will be testing you to know whether you understand that a cold nodule is concerning for possible thyroid cancer. Next, what is a discordant thyroid nodule? This is a bit of a tricky concept that took me a while to get a hold of as a trainee. Let's go through it. A discordant thyroid nodule is a thyroid nodule that shows increased uptake on a Technetium 99M scan, but decreased or absent uptake on an I-131 or I-123 scan. Let's unpack this a little more. First of all, the problem is that some thyroid cancer cells may retain enough function to trap, but not enough function to organify. Remember that we covered on the last episode that technetium and radioactive iodine are both trapped, but only radioactive iodine is organified. So a warm or hot nodule on a Technetium 99M scan is not necessarily benign, as technetium can be trapped but not organified by the thyroid. The take-home message is that one needs to be careful calling a nodule benign based only on a Technetium 99M thyroid scan, and a nodule may only be considered benign once you show that the nodule is also warm or hot on an iodine thyroid scan. I hope that makes sense. If you need to read through this a few times, you can download the study guide when it is posted on my website. Otherwise, feel free to ask your nuclear medicine physicians to explain this to you further. Again, the key message is that uptake on a technetium-only scan in a thyroid nodule does not necessarily mean that that nodule is not cancerous. You really need to rely on radioactive iodine. And the discordance can be the fact that a nodule that is cancerous can potentially have uptake on a technetium scan, but when you get the iodine scan, all of a sudden you realize that that thyroid nodule is cold. And that is due to the difference between trapping and organification in the thyroid. Next question. What are top differential considerations if the thyroid takes up Technetium 99M on early images, but not radioactive iodine at 24 hours? Potential causes for this finding may include congenital enzyme deficiency that interferes with organification versus therapy with something like propylthiouracil that blocks organification. But what we are getting at is an organification issue where you do see the technetium uptake in the thyroid, but not radioactive iodine on more delayed images that would require organification in order to hold the iodine in the thyroid. That is enough for now. On the next episode, I will focus on thyroid cancer and radioactive iodine therapies. Make sure to listen to that episode if these are areas you are weak on, because these are highly tested. You absolutely need to understand radioactive iodine therapy for any radiology or nuclear medicine board examination. Thank you for listening to this episode. Remember that you can follow at RadRev Podcast on Twitter or Instagram for near daily physics tips that I am at least currently posting on those platforms. Keep up the good work. Study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.